this worsening renal function is definitely associated with much higher morbidity and mortality. Worsening renal function is defined as a creatinine increase of more than equal to 0.3 milligram per deciliter between baseline and day 4. We know a lot of trials like ADHERE, OPTIMIZE, heart failure, and Euro heart failure have shown that 30 to 60% of patients who are hospitalized for heart failure have a glomerular filtration rate of less than 60 ml per minute. Again, this leads to increased morbidity and mortality. Now we know the RAS analysis, the essential findings of this meta-analysis was that RAS inhibitor induced worsening renal failure in both phenotypes of chronic heart failure compared with placebo. Worsening renal failure in patients with HFrEF randomized to RAS inhibitor was associated with a slightly worse outcome as compared with patients with without worsening renal failure. The incremental risk of mortality is much higher, and patients who have HFpEF and who are randomized to RAS, they also had a worse outcome as compared to patients who did not have any renal failure. Worsening renal failure causes decreased survival, and there are several hypothetical mechanisms, that is inflammation, oxidative stress. We are going to go into that further details. And it is very difficult to determine whether the frequently observed association of worsening renal failure is either the result or the cause of heart failure. The major causes of heart failure being hypertension, diabetes, atherosclerosis, LV dysfunction, and these are also causes which can cause CKD and renal failure. Patients having heart failure may already have a pre-existing kidney insult. They all have an increased venous pressure, neurohormonal activation, hypoperfusion, and there are a lot of drugs. We are going to see that in greater details. The major mechanism of worsening renal failure in patients who have heart failure, there is decreased output, there is increased activation of ventricular and arteriolar receptors, stimulation of sympathetic nervous system, increased systemic and renal arterial vascular resistance, maintenance of arterial circulatory integrity. There is, of course, retention of renal sodium, renal water retention. All these are interdependent, and one can lead to worsening of the other disease. Here we can see in this diagram, it is explained in great details. The main pathophysiological mechanism of impaired renal function in heart failure is the activation of the neurohormonal axis, specifically the sympathetic nervous system, renin-angiotensin-aldosterone system, and the arginine vasopressin stimulation to compensate for the decreased cardiac output or stroke volume in heart failure. The resultant increase in systemic vascular resistance includes vasoconstriction of the kidneys. The severity of renal dysfunction correlates with increased mortality and rehospitalization. Now here we have a lot of drugs that we are using for heart failure, for diabetes, and for various other conditions. They can cause kidney injury, they can affect renal impairment, and they can cause acute decompensated heart failure. Majority of the drugs is metformin. Metformin, as per guidelines, can be used up to CKD 2B. But if you have heart failure and renal dysfunction, we have to be careful. A lot of patients these days come with chemotherapy. Antibiotics and NSAIDs are very freely prescribed in our situation. There are lots of other conditions, patients having fever. Most of the NSAIDs in our situation are even self-medications. So this has to be explained to all patients. And as per guidelines, almost all our patients are on ACE or an ARB, aldosterone receptor antagonists. And diuresis, again, is a double-edged sword. It could either cause overhydration or dehydration and lead to affection of the kidneys. Now here there are a lot of predisposing factors for a cardiorenal syndrome, and all of them affect the heart as well as the kidneys. So from a normal kidney, it doesn't take long to get a diseased kidney. We will see all these conditions in details. Obesity and cardiometabolic syndrome. Adipocytes will secrete a lot of cytokines, and cytokines will cause cardiac as well as renal injury. Cardiometabolic syndrome in the absence of frank diabetes has been associated with a 3 to 7-fold increase in the risk of a cardiorenal syndrome in a variety of clinical settings. So weight reduction again is an important factor. Apart from obesity, cachexia on the other extreme, again sarcopenia and cachexia are again associated with a higher morbidity and mortality. Hypertension and diabetes is a very well-known culprit, and I'm not going to go into the details of this. Proteinuria, a urine exam in these patients is of course very important because proteinuria is an extremely important setting. Albuminuria and cross-proteinuria are associated with AKI and its risk. Albuminuria in the general population is predictive of development of heart failure, and in those with established heart failure, it is present in 30% and associated with hospitalization and mortality. Uremic solute retention. Now, uric acid is another target these days for treatment in heart failure. All patients should undergo a uric acid assessment and treat it if it is high. Anemia, a lot of discussions are going on anemia in heart failure. Anemia is associated with increased mortality, morbidity, and worsening of renal function. Now, repeated episodes of subclinical AKI, which the cardiologist treating the patient may not even be aware of. It can occur in cases of extreme dehydration with self-limited GI or a viral syndrome. After elective surgery, toxic therapies for other diseases like we've seen earlier, and use of iodinated contrast for a variety of imaging studies. Patient may even have had an episode of diarrhea, vomiting, or an acute gastroenteritis which might have led to some amount of kidney injury. Repeated episodes of subclinical AKI in the past may explain why some individuals with seemingly or no baseline CKD develop CRS in the setting of acute decompensated heart failure. Now, coming to management strategies. Volume and blood pressure management, it's a very extremely small window for this, and we need to be very careful. According to the ESC guidelines, we have to, patients with worsening renal failure, ARNI and SGL2 inhibitors are started. The initial decrease in GFR may decrease, but you need to continue these. It may cause a slight increase in serum creatinine. These changes are generally transient and they occur despite improvement in patient outcome and slower worsening of renal function in the long term. Sacubitril valsartan are also important. Even diuretic therapy has to be tailored well. I am going to skip a few of these slides and come to sotagliflozin. The new sotagliflozin has definitely shown much more promise in the SCORED and the SOLOIST trial. The major reason being SGL2 inhibitors act entirely on the kidneys and their effect of glycemic control is blunted by renal dysfunction. But sotagliflozin also inhibits SGLT1 enzyme, which functions in the gut to transport glucose out of the digestive tract and into the blood, a glycemic control pathway that is independent of renal function. Thus, sotagliflozin definitely has an edge over other drugs in its class compared to empagliflozin, Cana, or DAPA. Now, the newer drug finerenone. Now, there are two trials again for finerenone, and they have that spectrum included patient with an estimated GFR as low as 25 ml per 1.73 meter square, and patients with micro or microalbuminuria as well as patients with normal albumin. So the purpose of this fidelity trial was to perform an individual patient-level pre-specified pooled efficacy and safety analysis across a broad spectrum of CKD to provide more robust estimates of safety and efficacy of finerenone compared with placebo. So I'll just go to this. Now this again shows that finerenone definitely had a major benefit in these situations because it's a non-mineralocorticoid receptor. This is a new marker. Newer therapies like renal decompression, but to summarize, worsening renal function is a therapeutic challenge in management of heart failure. Treatment strategies need to be modified on a case-to-case basis. Newer modalities like finerenone and sotagliflozin definitely show promise. Thank you.